All right. So as I've said, welcome to the April 9th session of Topics in Trauma Nursing. Thank you all for being here tonight. I think we've got a great talk for you tonight with Amber Bartal coming at us from Robert Wood Johnson, New Brunswick campus, the mothership of trauma for Central New Jersey. Yes, there is definitely a Central New Jersey, in case any of you wondered. And she'll be doing a talk tonight on assessment intervention for hemorrhagic shock. We were talking before everybody came on, and I said I'd love to get kind of the juices rolling with topics in trauma nursing every year with a good juicy hemorrhage talk. So I'm very grateful for her for coming on tonight and chatting with us a little bit about this very important topic, whether you are a trauma center based provider or not. Understanding the mechanisms behind hemorrhagic shock and identification of hemorrhagic shock and what to do for it is important, whether it's for your trauma patient or for your medical patient as well. Um, so without further ado, we'll chat a little bit about it. So for those of you that haven't joined us for a topic session before, this is a quarterly educational offering, and it's really designed to bring out cutting edge topics in trauma care to emergency and trauma nurses. Started off to be in New Jersey, but I can tell you tonight on the call, we've got a number of nurses from outside of New Jersey. And then when this ultimately is recorded and put up on my YouTube page, there are some subscribers up there, not a lot of them, but some subscribers up there that are across the country. So we are not just a Jersey-based phenomena anymore, but I do really put this up and have the topics concept up there for those of us that are Jersey born and based. And the goal was really simple. Just sit back, enjoy. We do want you to ask questions. So if there's something that, Amber talks about and you want a little bit more information, you want some clarification from it, that's perfectly fine to do. Again, use that chat box feature and we'll have the ability once she's done to answer any questions she have. We'll also bring you everybody back on live when we're done. You can turn your cameras on if you want, and you can ask any questions of Amber at that time. Um, I've already got the next session of trauma. It's up and it is running. I'm ready for June 18th. We're actually going to be doing a reprise of a talk that Kathleen Robinson and I did in Atlantic City at the Emergency Care Conference just a little over a month ago. And that is there a nurse on board? What you should know to survive an in-flight medical emergency. So if you did not attend that in Atlantic City, then I wholeheartedly recommend that you hit that QR code. And I'll also be sending this out to everyone who registered tonight and everyone who's on my email list as well, so that you can get yourself in line and participate in our next session. And speaking of Kathleen, there she is. She just popped on the screen just like magic. So again, I wholeheartedly recommend that you do join us on June 18th, and I promise you, you won't be disappointed with this fine talk from a very fine lady. Um, Continuing education credit for tonight, it is available. What we'll do at the end is I'll flash up a QR code. I'll also put a link in the chat box that'll let you go and do a quick Survey Monkey post activity evaluation. Claim up to 1 contact hour of credit for tonight, and then also provide us sister feedback. Tell us how we did tonight, and more importantly, tell us what you'd like to see in future episodes, if you will, of topics in trauma nursing. And then let's see, boom. So I'm going to go ahead and stop sharing my screen. Amber, I'm going to let you go ahead and take control and you can share your screen and
Okay.
we'll get on with it. What do you say?
Sounds good.
All right, cool beans.
Mm.
All
Everybody.
right, very good. I'll let you take over, introduce yourself, and educate us, as they say.
Okay, I'll try my hardest. Hi, everyone. I'm Amber. Some of you I know, most of you I don't. So, hello. Um, I'm here to talk to you about hemorrhagic shock and what we do for it. So, who am I? I am a nurse at Robert Wood. I've been there for the past almost 5 years, and I started my career there. I've worked in the ER there only in trauma, and then the way our hospital is set up is that our ER is rotated. So you work in trauma, you work in fast track, you work in triage, you work in the main ER. So I kind of went through it all. And then recently in September, I transitioned and I am now the trauma educator for our hospital. So what I do is I provide education to nurses, CCTs, residents. I participate in our PI program, so identifying where we can improve. And then I take it back to the units and I develop plans with the nurses and figure out how we can do things better for the patients and better for the nurses and make our teams work a little bit more cohesively. And our hospital is pretty large. We have a level one adult trauma center, level two pediatric trauma center, and we see about 3,500 patients a year in trauma. So when our patients come in bleeding, I think most of the time we're like, we need to stop this bleeding. So we teach people in the field how to stop bleeding by applying tourniquets and applying compression and wound packing. And that's all good temporary measures, but we really need to see when the Oh, sorry, Steve. I was like, does someone have a question? We really need to kind of be able to notice when our patients are losing too much blood and then do the proper interventions. And I know that I've been in the position where I have this patient who is stable-ish, waiting for the OR or waiting to go to IR. And I'm kind of sitting there thinking, can someone please be here to help me? Because I don't like this could go wrong very quickly. And I think that's why we need to practice learning about hemorrhagic shock all the time because these patients can really change really quickly, and we need to be able to recognize that. So what is hemorrhagic shock? So if you're a trauma nurse or you work in a trauma hospital, or even if you don't, you probably know that there are different training programs. So nurses usually get trained through TNCC or ATCN. Those are both nurse-driven training programs. And then the physicians are trained through ATLS. And ATLS is Advanced Traumatic Life Support. And that's what this classification here is based on. So ATLS classifies shock in 4 different ways. So you can see class 1 is those are patients that lose less than 750 mLs of blood. So we can compare this to someone that donates blood. Normal blood donations, you're giving about 450, 500 mLs. And so after that, you might feel a little weak, a little tired. You might be a little tacky, but your blood pressure is probably going to stay normal. You're going to still be peeing normally. You're not going to be breathing too fast, but you're going to have to like rebuild those cells. Class 2 is a big jump. So we're losing 15 to 30% of our blood volume. And these patients, they're going to start looking a little different. So they probably are still going to have a normal blood pressure, but they might be a little bit more tachycardic. They might be a little bit more anxious and they might start breathing a little faster. And these patients are in a compensated shock state. So they're still doing okay. They can make themselves get through this, but they're working. And then class 3 and class 4 these patients are really losing a lot of blood volume. So the difference between these two classes is only about 500 mLs. But these patients are going to present pretty tachycardic. They're going to present with hypotension. They're going to be breathing fast, and they're going to be having an altered mental status. We really want to try to avoid getting into class 3 and class 4 hemorrhagic shock states because once we get into these zones, it's going to be harder and harder to try to recover these patients and get them back to baseline. So, where do we bleed from? So, trauma patients obviously bleed from all different sites. They can have lung lacerations from blunt chest wall injury, a rib cracks and slices their lung. We can have solid organ injuries. So if you have blunt injury into your abdomen, you have a liver laceration, kidney laceration, spleen. And then you can have fractures. So we can have long bone fractures, which can bleed a lot, and pelvic fractures that can bleed a lot. And then we can also have injured vessels. So our vessels can get sheared from just plain force from either a penetrating injury or a blunt injury, but they can also get sheared from bones. So a common place to have sheared vessels is in the pelvis from a fractured pelvis. But we should also remember that this isn't just for trauma patients. You can be bleeding for many other reasons. We can have a GI bleed. Maybe someone is on a blood thinner and they have an ulcer and now they're bleeding. Or We have esophageal varices. We have a ruptured aneurysm. We have a cardiac problem happening. We have an abnormal uterine bleeding from pregnancy. Or this person is on dialysis and their fistula starts bleeding and they're really, everything else is fine, but they're bleeding from this access site. So we really can't just think about hemorrhagic shock for trauma. It can happen in all different types of medical situations. So when we're talking about these different areas of bleeding, a lot of the times when we're seeing bleeding, it's going to be happening on the floor, right? So we see this blood pouring out of someone and we're like, wow, that looks like a lot of blood. And we have to think about the different types of areas people are bleeding on. So if we're in the hospital and they're bleeding on the floor, we can see all that blood. But sometimes when EMS is bringing these patients in, they're on grass or carpet or something that's going to absorb that. And we might not see everything that they lost. But we also probably won't see blood that is stuck inside a compartment. So if they're bleeding from different types of orthopedic injuries, your body cavities can take a lot of blood without you knowing it. So your femur can take up to 1,500 liters in your thigh. So it seems like a lot. And your long bones in your arms can also take up to 750 mLs of blood. The pelvis can hold up to 3 liters of blood in the pelvis. And sometimes you won't ever see that blood until you either put a Foley in or they're so hypotensive that they need to go to you need to start MTP and go to the OR. So it's really important to recognize that just because you can't see the blood doesn't mean that person's not bleeding. So what does it look like when someone comes in hemorrhagic shock or in shock in general? So when they're probably going to have some sort of altered mental status, like we talked about. They're becoming more altered as they lose volume, increasing tachycardia. They're going to have decreased urine output, narrowed pulse pressure, prolonged cap refills. They're going to be cool, clammy, moist, and obviously have hypotension. The reason why we're seeing decreased urine output in these severely shocky patients is because that's the first organ that your body is going to kind of push to the side and shunt blood from, because we want to push that blood to the more vital places. So once we start seeing the kidneys not produce urine, we should be thinking something is wrong. One of my mentors who's on this call taught me that your kidneys are the window to your soul, I think she says. So you have to always pay attention to them because you'll really see what's going on. If you notice your Foley bag or your Pirouette canister is empty, something is wrong. So ways that we can identify people going into a shock state before we start seeing all these classic signs that are really bad and are telling us that our patient is really sick are by looking at subtle signs. So one of those subtle signs can be a shock index. A shock index is an easy, quick measurement that you can do by looking at the heart rate over the systolic blood pressure. And when you're looking at this, you can see someone and say, oh, their shock index is, we say greater than 1 is an easy way to think about it. And if they're greater than 1, then we should be thinking in our head that there's something wrong and we need to intervene before it gets worse. So a good example I like to use for this is you have a 23-year-old MVC. They are complaining of belly pain. EMS calls you, says, we're bringing this person in and their vitals are 130/75 and heart rate is 150. And you're like, okay, that really doesn't sound that good, but we'll see him when he gets here. When he arrives, comes in, he's real anxious, trying to move off the stretcher. His heart rate dropped a little bit, it's 140, but now his blood pressure is like 108/70. So just because these vitals are somewhat normal, like he's not profoundly hypotensive yet, he isn't unconscious, he's still moving, he's talking, you're thinking he's anxious just because he was just in a crash, maybe he hit his head, he's a little confused. We should be thinking that he's complaining of abdominal pain. He was just in an MVC. His shock index is much greater than 1. Maybe this person has a pelvic fracture that we can't see he's bleeding from, and we need to really intervene and do a full assessment on him. So now moving into hemorrhagic shock and what's happening in the body. So there's a phenomenon called the trauma triad of death. And I'm pretty sure if you've talked to Steve before or you're in the trauma world, you've heard of this. And this triangle that is composed of hypothermia, acidosis, and coagulopathy. And this triangle basically is like the Bermuda Triangle. Once you get in, you can't get out. So what we want to do is try to avoid any of these things from happening to give the best outcome for our patients. Recently, there's been a lot of research and movement towards the trauma diamond of death or the lethal diamond of death. And this is adding hypocalcemia into this negative cycle. And the reason why we add hypocalcemia in here is because most of the time when we have a patient that is bleeding and is stuck in this trauma triad, we are trying to fix it by giving them blood products. When we're giving lots and lots of blood products to people, especially PRBCs, those blood products have to be preserved somehow. And the way that they're preserved and they don't stick together is by being processed with citrates. So when the citrates are put into the blood, it makes it so they don't stick together and they don't really go bad as easily. And it's better than putting in drugs such as like blood thinners because we don't want to put those into people that don't need them. The problem with the citrates is when you start transfusing this into people, the calcium that's already in our bodies binds to citrate. So what happens is as you're transfusing this person more and more, their calcium drops because it's binding to the citrates in the transfused blood, and they're becoming hypocalcemic. And we know that calcium is an important element for our heart system to fire correctly and work correctly and protect it. So we can start seeing like antiarrhythmics and stuff like that. So what we want to do is try to replace that calcium by giving amps of calcium while you're giving blood products to avoid this. So what's happening when we actually are bleeding and the patho of it? So once you start bleeding, we're losing blood, we're becoming hypovolemic. And what happens then is that you're not adequately perfusing, right? Because there's not enough blood circulating around to get everywhere. And it's not that we're going to give a little to everywhere. Your body is not going to give a little bit of blood to everywhere. It's going to take the blood that it's needed in the places that needs it most. And then the other places are not going to get as much. This leads to cellular hypoxia. So your cells cannot breathe as easy and they can't get their energy. Normally, we go through aerobic metabolism, which is we take oxygen off the hemoglobin. We go through this cycle, make some ATP. ATP keeps us running and we're all happy. When we don't have any oxygen, what we need to switch to is anaerobic metabolism. And what anaerobic metabolism is when your body starts breaking down your stored energy in order to get energy itself. So that could be through like sugars and stuff like that. When this happens, there's a byproduct, and the byproduct is hydrogen. So this hydrogen just gets released and that gets built up in your blood system. When you have excess hydrogen, you're going to become more acidic because hydrogen is an acid. So your lactic acid levels are going to rise. And when your lactic acid levels rise, your cells start to swell. And this leads to further acidosis, which when you're acidotic, your clotting cascades don't work. They can't start and they can't release the elements that are needed to start the clotting cascades. And then you start bleeding more. So you just get stuck in this cycle and we can't really get out without some sort of intervention happening. So this is a graph that shows you what is happening with acidosis. So it's a little hard to understand, and I'll do my best to explain it. But pretty much this curve is showing at those red dots that we're looking at 7.4 is like normal pH, right? And at 7.4, we are basically running at like a normal rate. So for like our clotting factors are being activated and then the chain is starting at a normal rate. Once we drop even just a little bit, so if you look at this graph, even just dropping to 7, we're almost decreasing the effectiveness of our activation by half. So even a small change in the pH of our body can really affect how fast our blood can clot and how effectively it can clot. And you can see by the time you're getting into the like not even almost at 6, just a little under 7, you're basically not clotting at all. You can see in the blue, even mildly acidotic can affect coagulation. For example, a pH of 7.2 may reduce some steps of enzymatic coagulation by roughly 50%. So from 7.4 to 7.2, you're already losing a lot of your coagulation. So if we remember back to the trauma diamond, trauma triad, the other point is hypothermia. So hypothermia is defined as a core temp of less than 95 degrees Fahrenheit or 35 degrees Celsius. And why this is important is cold patients can't clot. So if you're cold, your clotting factors aren't working and your platelets aren't working. So this means that we're going to keep bleeding and there's nothing we can really do to stop it. You can see that once we get into moderate and severe categories of hypothermia, so from 90 below, our mortality is really not good. We also need to think about that hypothermia can occur because of the elements, right? So it can occur because our trauma patient was just in an MVC. They're laying on the asphalt in the middle of winter for 15 minutes. They're going to be cold. Or they're driving their car, they crash into a river, and they're in the cold water for extended amount of time. Those patients are going to be cold. But also, these patients can be cold if they already don't have any blood. They're laying on a cold stretcher in a hospital with no clothes on in an operating room. They're going to get cold as well. So we want to just make sure that we're thinking about this outside of just the initial rewarming phase from the elements, that we're keeping them warm throughout their whole stay. So this is a cool study that was done by Arcans and some fellow colleagues. They looked at a population of about 2,000 patients. Of those 2,000, 250-ish were hypothermic and 1,700 were normothermic. They compared these two populations on elements of ICU admission, overall mortality, MTP activation, and if they needed some blood products. I highlighted in red the hypothermic patients. 85% of the hypothermic patients got an ICU admission, as compared to 61% of the normothermic patients. 43% of the hypothermic patients had an overall mortality, as opposed to only 14% of the normothermic patients. And 22% of the hypothermic patients had MTP activated, as opposed to 3% of normothermic patients. And then 37% got blood products of the hypothermic patients and only 11 of the normothermic. So you can see it's pretty drastic just how many more resources these cold patients need in order to try to get them to survive. Ways that we can keep people warm. We can do it with warm blankets, which is always great. But what we really want to do is kind of use our resources that we have and use the machinery we have to warm them from the inside out as well. So if we're giving them blood products, we're going to be giving them warm products through a Belmont or a rapid infuser, level 1, something like that. We're going to be giving them warm fluids. Either they're warmed in a warmer, they're warmed through a hotline. If we have blankets on them, we're going to make sure that they were warm before we put them on. We can use a bear hugger. Other ways that we can keep people warm is if, say, we're doing some sort of like lavage of the chest or belly, which we normally don't do. But if you are, you're going to be using warm fluids for those types of things as well. So, blood resuscitation. If it doesn't carry oxygen or it doesn't clot, don't give it to me. We should not be replacing these patients with normal saline or LR. That's not what came out. That's not what should be going back in. If you're crossing over 3 liters, that's the wrong direction. We want to be replacing these products that the patient actually lost so we can replace the clotting factors and all the things that they really need. So we want to be able to early diagnose these patients, and in that sense, we're identifying the early signs of shock. So we're looking at those class 1, class 2 stages of shock, the mildly anxious, the slowly creeping up tachycardia before we get to hypotension and mental status changes. If we do start giving blood products, the way that we're going to do it is in a balanced resuscitation. So we're going to be giving a 1-to-1-to-1 ratio. So we're going to be giving a PRBC to an FFP to a platelet if we have it, and trying to stick to that ratio as much as possible. We don't want to flood these patients with PRBCs, just like we don't want to flood them with LR. And the reason is because the RBCs don't have anything that they need. They have oxygen carrying capacity, but they don't have any of the clotting factors that are keeping them that they need in order to stop this bleeding. If we get cryo from the blood bank, we want to give that as soon as we can. This is not always going to be early to give because it has to be defrosted. But when we give it, or when we get it, we want to give it. We also want to be thinking about whole blood. So we'll talk a little bit more about whole blood in a few slides, but whole blood is really being brought into a lot of centers, especially in our state. And the benefits of it are really great. And the deficits of it are really pretty much none. So if we can transition to giving whole blood to most of our patients, I think we could probably see some really good outcomes. We can also utilize something called TAG or ROTAM. This is a blood test that can be done. Basically, what it does is you draw the blood from the patient, and then when it's spun, it mimics a clotting cascade. So it can tell you exactly where that blood is the clot cascade is breaking in order for the surgeon to replace the appropriate products. So can tell them if this patient needs cryo, if they need platelets, if they need FFP, if they need something different. There are some drawbacks with this. It takes a little while to run, like 10 or 15 minutes. So it's not an immediate test unless you have like a point of care, which are usually very expensive. And then also the test isn't always resulted in a nice, clear way that just pops up and says, give platelets. It kind of pops up in the clot cascade. So the surgeon has to read it in order to identify exactly where something's not being activated. So not every person is able to read these tests. And then we want to eventually stop the bleeding, right? So these patients are not the type of patients that we're going to be thinking about if we can get them to IR because they have a nasty pelvic fracture, or if we're going to be trying to control bleeding with pressure. If we're in a hospital setting, these patients should be getting to these definitive care areas quickly because there's nothing else that we can do. We can keep replacing whatever they're losing, but if they don't get that fixed, they're just going to keep losing it. So whole blood really has all the things we need, much more than component therapy. So when you're giving whole blood, it comes in about a 500 ml bag. The reason why it comes in a 500 ml bag and why you're giving that much volume is because when you donate, like I said, you're giving about 450 mLs of blood. So by the time they put the additives in it, it's about 500. And then it has your hematocrit, it has your platelets, it has all your coag factors. When you are using component therapy, you take that whole blood that's been donated, they spin it down, break it apart, and then separate package it. And by the time they do that, with all of the processing, we really lose a lot of the things that we need. So you can see that the hematocrit, after you give a balanced resuscitation of PRBCs, plasma, and platelets, your hematocrit's only 29%. And you can see in whole blood, you're getting a lot more, almost up to 50%. And then your coag factors, you're only getting 65% of them, when really, if we're bleeding, we want all the coagulation factors that we can get. And also, we're getting more volume overall. So 3 units of component therapy, you're getting about 650 mLs as opposed to the 500 of whole blood. And we know that we don't really want to like give these patients too much fluid because we don't want to fluid overload them because we see problems with that as well. So if you have the capability to give whole blood and the patient is able to tolerate it, they should be getting it. And there's really no negative repercussions of getting it. There's still research being done about women of childbearing age receiving whole blood and children receiving whole blood, but there has been studies done, and the people that have gotten it have not gotten any adverse reactions. With whole blood for children, the thing that they're seeing is that the volume is a lot. So sometimes if you're trying to transfuse a small pediatric patient, that is too much volume for them to get in that rapid sense. So the cost versus benefit there is it beneficial to use this whole blood that has these like great factors on this pediatric patient and maybe waste some of it, or do we give them component therapy and then save this product for someone who can use the whole bag? I just read a really good article about this and presented to all my units last month, and I did not cite it here, but if anybody is interested in that article, I can share it with you after this presentation. So the reason why we are seeing more whole blood and where it even came from is because the military did this. And the way they did it was they used literal walking blood banks. And what a walking blood bank is exactly what you think it is. It is a person that gives their blood to the person that needs it. And then it's a transfusion person to person. When they were doing that, they were obviously getting the whole blood because they weren't taking it out, processing it, and then putting it into the wounded soldier. So after they did this for a while and they saw it working, they decided to bring it to the civilian world and use it. And they started using it. And what we found was that once patients started using it or started getting it administered to them, they were the fourfold increased survival of this population and a 60% reduction in overall transfusions. So it's really pretty significant data that's showing that it is much, much better than getting component therapy. But like with everything, there's drawbacks. So we're doing everything we can to identify that these patients are bleeding. We are then doing early interventions to stop the bleeding or recognize that they're getting shocky. And then we're treating them by doing transfusions or giving them medications or doing something. But even after all this, they can still have something wrong. So some of the things that we see go wrong, like we talked about before in the trauma diamond, is hypocalcemia. So that's why we want to give an amp of calcium about every 2 to 3 units. You can give calcium gluconate or calcium carbonate. They're both, they don't really have a difference, I guess. And Steve can chime in on this. I can't remember which one is more, they give more, but he can.
Calcium chloride is more concentrated.
Yeah.
Yep, exactly.
Um,
Three times more calcium and calcium chloride than calcium gluconate.
Yeah. So usually you'll give a calcium chloride, but either one is fine. And then you can also see DIC. So DIC is when you're clotting, bleeding, and you're kind of bleeding from everywhere that is not where you're like, not even where your wound is. So this is like an interruption in the clotting cascade and is pretty common after mass amounts of blood loss and then replacement. And then you can also see a phenomenon called taco and triali. And these are not going to be immediate. You're going to see them usually about at least 6 hours post transfusion. And what these are transfusion-associated lung injuries, and or circulatory overload. So TACO is similar to like any sort of CHF patient that you see. They're going to be overloaded. They can't clear the fluids. You're going to need to diurese them and try to get that extra volume off. Transfusion-related lung injuries are a little bit different. So what happens with transfusion-related lung injuries is that you have a patient that is getting all these blood products and they have a like autoimmune response to the antibodies in the blood. And what this does is it creates like mass amounts of edema in their alveoli, and they can't then breathe. So it's similar to an ARDS. So these patients are going to have to be treated pretty aggressively and basically we just have to wait for that edema to settle down. They're going to be hypotensive, both these patients. They're probably going to need supportive oxygen therapy if they're not already intubated. And they're going to need to maybe be on some pressors to get them through this time. Interestingly enough, patients that get whole blood are at a little bit higher risk for Triali just because of all the coag factors it has. And if the blood that is donated was from a previously pregnant person, they actually have a higher risk of the transfused person has a higher risk of contracting Triali or getting Triali as well, just because that blood already had like antibodies in it. So that is an interesting topic as well that I spoke about on my units, and I have this article, the Robian is a pretty good one and does a good explanation about whole blood and how it relates to Triali. It's pretty cool. So what's in the future? There's lots of things in the future, and I can't tell you them all. But what I can tell you is that we're going to start using blood in the field. So EMS is going to start giving blood to our trauma patients and some other types of medical bleeds in the field before they get to the hospital. Places that are doing this already in our state are Hackensack Aeromed and Gestat. And the Hackensack paramedics recently, like very recently, just in the past maybe 2 or 3 months, just got approved to use whole blood in the field. So they will start using that as well. And then Atlantic and University Hospital are on the horizon. They should be getting approved within the next few months. And then Robert Wood is also trying to do this as well. So hopefully we can get on board, and St. Joe's, and hopefully we can get most of the trauma centers in the state to start doing this for our most vulnerable population. What they found and why this is so important is that with every 1 minute delay for receiving blood products or treating this hypotension in the field from associated blood loss, there was a 2% increase in odds of 30-day mortality. So these patients losing this blood and not getting it replaced, the minutes really count. And that is why if we can't give them blood in the field and start this resuscitation early, getting them to the hospital so it can start as fast as possible is really super important, and really something that we should all pretty much strive to do if we work in the field. And that's really all I got for you. So I hope everybody enjoyed this, and I'll stop sharing so Steve can take over.
You've done a phenomenal job, Amber. Excellent, excellent, excellent job. So, thank you so much. So, from a question standpoint, we don't have a lot. Beth, if you just want to pop on audio here, did she answer your question? Or do you want some additional information with regards to what are the benefits of using whole blood over component therapy?
Oh, she did a phenomenal job and everything was answered. I appreciate it. I probably jumped the gun a little bit with that question, but she was talking about. I wanted to get it out there.
That's okay.
Yeah, great
No.
job.
No, it's
Great
great.
talk.
It's great. And one other thing, I mean, you saw when she put up that great graphic where it really you looked at kind of that head to head of what it's like to give the component therapy and what it's like to give whole blood from the standpoint of hemoglobin and platelet count and clotting factors. The other thing you also have to bear in mind is that you're also giving it from a pooled donor pool. So you do run the risk of having an increased risk of allergic reaction and also some disease carrying components there that you don't find with whole blood because it comes from a single donor. And definitely, the literature is showing that at least when it comes to any kind of immunogenicity, that they're seeing it's extremely low when using particularly the low titer blood that most of the trauma centers and the pre-hospital assets are starting to use. So
Do you know what
de-
the shelf life is compared to component blood to whole blood, like when the hospitals carry it? Is it about comparable or is it a little less than normal?
Yeah, it all depends on the component that's involved, right? So generally speaking, it's got about a 30 to a 35-day shelf life with whole blood. So that's why it's really important for both trauma centers, and particularly now that they're starting to use this pre-hospital, that there's a great either a high utilization of it, so they're wasting very little of it, or the pre-hospital assets are got exchange programs up with the trauma centers to have waste very, very low. I know in talking with Joe Solda over at Hackensack, they've got an extremely low waste standard for theirs. I can tell you at St. Joe's, we have a whole blood program in our trauma bay, like a lot of the trauma centers do now, and I don't think we've got any waste of whole blood whatsoever. We are either using it or it's at a requisite time, it's going to the blood bank, spitting it down and making component therapy out of it. Any other comments or questions? So anybody can come on. You can turn on your video if you want at this point in time, or you can just turn on your audio and, any questions for Amber?
Or tell us a story about a time where you had a patient in hemorrhagic shock and you were like, oh no, what's going on?
Oh, no. I have a quick question for everybody. How many of you in your facilities are using calcium or giving calcium regularly when you're doing MTP? Do you feel like this is becoming part of your practice or not?
I think I can talk for some of us, and anybody that's on this call from Memberwood can correct me if I'm wrong. I think we're trying to think about it more, but I do think it is sometimes forgotten. Um, but I think it's like a group effort where if the surgeon doesn't remember, the nurse remembers, and then, or the pharmacist remembers.
Yeah, very much so. What I've done at St. Joe's is on all of our level ones. I've got this chain that's got this card, laminated card, that has a picture of a hemorrhaging patient on it, and it says "Giving blood, consider calcium," and it's actually got a QR code to a great topics and trauma nursing conference that we did about a year and a half ago on the fatal diamond itself. So I think that that's a way of getting it and keeping it kind of in your face, that when you're actually hanging the blood, this thing's right in front of you to say, hey, are you giving calcium too? It looks like Say Wrong was saying that yes, they're definitely keeping it in their mind over at Morristown. So that's great. I think universally we're starting to catch on very, very importantly that, when we're giving this therapy, whether it's whole blood or whether it's the component therapy, that we've got to give calcium. So it looks like from the feedback I'm seeing that it's got good uptake. And bear in mind, we're talking trauma here, but this is also for your medical patients as well. You have your GI bleeds that come in, postpartum hemorrhages, whatever the case may be, and you're giving even component therapy to them still largely. Remember that for every, and there's no recipe out there. The evidence really is not saying every other unit, every third unit, but what a consensus is out there, as Amber said, is about every 2 to 3 units of blood or units of packed cells, you should be giving either the gram of calcium chloride if you've got a central lot in place, or 3 amps or 3 doses of calcium gluconate if you're giving it through a peripheral line. The pre-hospital setting is interesting because they are giving calcium chloride. There are several of the programs that are using it, like New Orleans, North Carolina, San Antonio, down in the Florida, down in southern Florida, they actually have resuscitative bundles. And the resuscitative bundles are we give blood or blood products, we give a gram of calcium, and we give 2 grams of TXA. So that's also in there as well. And we didn't talk about it as part of this, but TXA is also part of that kind of equation of the hemorrhaging patient that you want to give tranexamic acid. Not that it does anything other than it prevents the body, which goes hypercoagulable, from breaking down those clots that are actually starting to stop the bleed, and keeps them from breaking clots down really, really quickly over a period of about 8 or 24 hours.
For calcium gluconate versus calcium chloride, are there specific patients that would benefit from one over the other? I think if you have a central line, you would want to give the calcium chloride. If you don't, then it's just a higher risk for the patient. But either one is fine. I don't know about any patients specifically benefiting from one versus the other.
Yeah, it's all a matter of concentration, and it's a matter of one can go peripheral and one needs to be in a central line because of the extravasation risks. Although, once again, in the pre-hospital setting where they're giving calcium chloride in the field, they're not running into a lot of risks with extravasation. And sometimes they're just diluting the calcium. They're giving a gram of calcium chloride, but they're diluting it in 100 cc's of normal saline, and they're giving it that way. So they can give the higher dosing of calcium more quickly than they would if they have to pop 3 doses of calcium gluconate.
Yeah, Mary.
Yeah, the calcium chloride, I would say IV push, you got to be
Yep.
real careful. Calcium gluconate is totally safe to give IV push.
Yeah.
No problem. But the calcium chloride, be pretty careful. That's really kind of a code drug when you don't push it fast.
Yeah,
Yeah.
absolutely.
I think the 100 cc dilution, not supposed to do that in the hospital setting as nurses, but it's a good idea.
Yeah, I mean, I think they're finding that, a lot of the caveats that we've always done or not done in the hospital, it's like, why are we doing them? Let's call them into question. And, is there really a reason we should be working around that, if you will? So I think when you see these things happen, this is what really ultimately changes practice. I mean, let's face it, there are a number of us on the call, I'm sure, that are a little bit gray on the head that remember the days that we were giving 2, 3, 4, 5 liters of crystalloid to our trauma patients before we were starting blood, if we even started blood on them, right? And then we were drawing blood, and the vacutators were containing kind of this pink tinged fluid. And, if it didn't kick in there that we weren't doing something right with our patients, and guess what? It didn't, then, it's time for this paradigm shift for sure.
I believe that I remember teaching pals that you had to give first the 220 per kilo boluses before considering blood.
Same thing for TNCC. You gave
Yep.
2 liters of fluid, warmed crystalloid solution, and then you considered blood after 2 liters.
Exactly. Because remember, the ratio used to be, and I can remember this back when I first started working trauma, is for every 2 to 3 liters of crystalloid, you gave a unit of blood. It was kind of an admix that way. And again, now we think about that and we shudder. Hopefully we should be shuddering when we hear about that, but that was standard practice. And when I worked pre-hospital in the Midwest many, many years ago, we would high five ourselves coming into the trauma center with 3 or 4 liters on board. And yes, we had a blood pressure on the patient, but the survivability was like, a guppy out of water. It just, it isn't going to happen. So we definitely got to kind of take that into consideration. And to chat real quick about the pediatric considerations too. I know you're going to be wasting. There's the potential for wasting that precious, precious blood. But this is where, and Jeannie, close your ears here. But this is where I'll tell you that children really are little adults when it comes to what their need for blood products is. And we all bleed whole blood. We all should get whole blood. And yes, there is a risk with a child when you're doing a kind of almost like a push dose of blood therapy that, you're going to waste half a bag of blood. But the survivability is there. And looking at the data that's coming, particularly the pre-hospital data that's coming out of places like San Antonio and really more ardently New Orleans, Louisiana, is showing an increased survivability of 40 to 50%. Joe Solda, who is the chief flight nurse out at Hackensack, was telling me an interesting story at ECC a couple weeks ago that in Washington, D.C., when their fire department was trying to get the buy-in for the increased financing that came with giving blood in the pre-hospital environment, their chief was said the smartest thing, went to the mayor and said, Mayor, if I can guarantee a 10% decrease in homicides in the city, will you fund my program? And the mayor said, sure. Well, they have had a 30% decrease in homicides because by giving blood, their mortality has dropped that much. So, where somebody is being shot in the field and was dying and is now a homicide statistically, if they survive, they're no longer a homicide, right? So, it makes the mayor look extremely good that Washington, D.C. has had a 30% decrease in homicides. People are still getting shot, but they're just not dying anymore. And that's really kind of the miracle fluid that blood is in the pre-hospital setting. And it's really good to see that New Jersey finally came on board at the end of last year, approved it, got all of the waivers signed, and have made it now part of the scope of practice of the paramedic to be able to give blood in the pre-hospital setting. That's going to be a game changer for us in New Jersey. Absolutely.
I just want to tag on to the pediatric consideration, Steve, with regard to whole blood versus component therapy. I think they'd be equatable, if not even more waste. Thinking about the aliquots and the component therapy, when you do the 1-to-1-to-1, if we're doing this for hemorrhage control until you stop the bleeding, still transfusing with whole blood is overall probably going to be less of a volume and less of a problem for even a small child. Because you're replacing everything all at once, as opposed to, you see my beautiful forehead there. Sorry about my camera.
I was going to ask you, where's Waldo?
Because you're replacing, everything all at once, as opposed to the component therapy. So
yeah,
I don't think there's really a contraindication to the whole blood for children.
Yeah, absolutely so. And Joseph popped a comment up in the chat box, which we'll talk about is if you don't have whole blood, do you still prefer the fixed ratio of 1-to-1-to-1? Yes, absolutely. 1-to-1-to-1, or at least 1-to-1, and then you give your plasma, depending on the aliquots that come down, is still the way to go. That actually came from data that actually came out of the London trauma system about 8 or 9 years ago that really shows that when you are giving component therapy, you want to give it in a good fixed ratio that mimics whole blood to the extent you can. So if you do not have whole blood capacity, yes, 1-to-1-to-1 is still what you need to reach for when you're giving a balanced fluid resuscitation.
I think Joe meant for peds, like if you have a
I'm sorry. Yeah.
peds patient, do you still do that, or do you go to like are we just going to replace RBCs or FFP if that's what they're missing or whatever?
Gotcha. And it would hold true for the pediatric patient. You want to give them back to as physiologically normal what they're losing. So if you don't have the whole blood, then the 1-to-1-to-1 or 1-to-1-to-2, as some will call it, is certainly the advantageous way to go. Excellent questions. Anybody else have any questions? All right, so what I'm going to do here real quick is I'm going to share my screen for just a minute and we'll wrap some things up here. So here we go. So we've done the open forum. So again, if anybody else has any questions, please definitely put your chats in the box. A lot of accolades for Amber and doing a great job. And I agree 110%. Amber did a phenomenal job tonight.
Thanks, everyone. I told Steve before, I'm so nervous. What if they ask me a question I don't know how to answer?
You couldn't tell. You're an old pro.
That's why you have Steve to back you up.
Yeah.
We're all in this together, right? At the end of the day. That's one of the things I love the most about our trauma system in New Jersey is there is no fear, there is no sense of competition amongst trauma centers. It's we all work together for the common good of the patient. And we see this tonight with everybody who's on and the great conversation we're having back and forth. So to that, the next session of topics in trauma nursing, which isn't necessarily a trauma topic, but it is a fun topic, is there a nurse on board? What you need to know to survive an in-flight medical emergency. Again, this will be a reprise of a talk that Kathleen and I gave in Atlantic City just about a month ago. So please, if you're interested, hit that QR code and register. I'll also be emailing this out to everyone who registered for tonight, whether they actually called in or not. I'll send this flyer out to you. And, certainly for those who are out there, please take it out, post it, forward the email to any of your colleagues. The more people we can get involved with these programs, I think the better off we all are. Okay, so the important thing, get your CE and evaluate Amber. So you guys are all putting these great comments in the chat box, but now go and put keyboard to paper and either hit this QR code, or I'm going to throw in the chat box here if I can get my cursor over to figure things out here. There we go. Boom. In the chat box, I just put a link that you can go and do the evaluation. So again, give us your feedback. We want to hear how tonight's session went, whether it was beneficial to you, and more importantly, what future topics would you like to see presented here? And also, if you're interested in presenting a topic in trauma nursing, and it doesn't have to be totally trauma, we'll let you get by with someone it's emergency nursing centric, then put a comment in the comment box and say, hey, I'd like to consider talking at one of these things, and I'll reach out to you, and we'll see what we can do to get you live on the computer. So go ahead and click this box. What I'll do is probably over the next couple of days, those of you that are doing your evaluations, I will email you your CE certificate. So make sure you put your email address in the box in there. And then if you're not already part of my email list subscriber, please check the appropriate box that you want to be put on the email list. And I promise I won't flood your email box with anything more than just nice little future flyers for both topics in trauma nursing as well as the Trauma Nursing Journal Club. Okay. So without further ado, we're almost at the 1 hour mark, which is great. Also, I'll give my shameless plug for my YouTube channel. This will be posted probably in the next 2 or 3 days on the YouTube channel. I am the Trauma Geek. Literally, yes, I am the Trauma Geek. And so I also have a YouTube channel. All of these topics in trauma nursing and other topics that I've done are posted on this YouTube channel. I think I'm up to about 24 or 25 different videos and topics on there right now of interest both for emergency nurses, trauma nurses, and since I dabble just a little bit in the pre-hospital environment too, there's some pre-hospital cool stuff up there. So you can certainly find me there and even subscribe. I think I'm up to a whopping 129 subscribers as of this morning. Whoop, whoop. So maybe one of you will make it 130. And then last but not least, that's it. So I come to a blank screen. It tells me that I am done and over. So again, thank you all for your time tonight. Appreciate it. Amber, thank you once again. This was absolutely a
Thanks
phenomenal
for having me,
night.
Steve.
And you guys all take care. Kathleen, it was good to see you. Jeannie, it was good to see you. Thank you all for hopping on board, and we'll see you in the trauma bay. Take care.
Thank you.
Bye all.